welcome to GP Notebook TV. My name is Dr. David Miller-Jones. Today I'm going to talk about tinnitus. Tinnitus assessment and management, in particular related to the NICE guideline published in March this year 2020, the NG155. It's important to be aware that tinnitus is common. Approximately 10% of the population will suffer from tinnitus at some point in their lifetime. In about 2.8% of the population, it will be moderately annoying, and in 1.6% of the population, it will be severely annoying. About 0.5% of the population will find it so annoying they will be unable to function normally. It's estimated that 3% of the adult population will require some form of intervention for the tinnitus, but remember, it can also occur in children. Tinnitus is often associated with hearing loss. 75% of people with hearing loss will experience some element of tinnitus, but conversely, 20 to 30% of people with tinnitus will have normal hearing. When we see patients with tinnitus, it's important to reassure them. Tinnitus is common. It may resolve by itself. It is commonly associated with hearing loss, but is not commonly associated with other underlying physical problems. There's a variety of management strategies that may help people to live with tinnitus. It's important to be aware that some patients with tinnitus may need to be assessed by a specialist. And the guidance is that we should be referring patients immediately if there is a sudden onset of significant neurological symptoms or signs. This would include facial weakness, if there is an acute uncontrolled vestibular symptoms, such as vertigo, or the suspicion of stroke. Patient should be seen within 24 hours if it is associated with sudden hearing loss that has developed over a period of 3 days in the past 30 days. Patient should be referred if they have ongoing distress from the tinnitus or if there is a longer history of hearing loss, and normally these patients should be seen within 2 weeks for assessment. When we see patients with tinnitus, we should assess the impact it has, the impact in their quality of life and also their sleep pattern. It's important to do a psychological impact on tinnitus, and the Tinnitus Functional Index has been advised by the NICE committee. This provides a broad assessment of the impact of tinnitus and incorporates a variety of components. It also specifically is designed to measure a change that the patient may experience. Now, in primary care, we're not particularly keen on using questionnaires, but this may actually give us a bit more impact. The other important thing is tinnitus can cause anxiety and depression, and anxiety and depression can lead to worsening tinnitus. So doing a mental health assessment is important. So with our referral, what investigations should a patient be experiencing? Audiogram assessment may be effective. If there is a degree of hearing loss, by improving the hearing, the impact of the tinnitus may lessen. Tinnitus may be pulsatile or non-pulsatile. In patients who got non-pulsatile tinnitus, we should be offering MRI scans of the internal auditory meatus, particularly if it's associated with neurological, otological, or head or neck signs. This may exclude vestibular schwannomas or brain tumours, or indeed vascular arteriovenous malformations. MRI scans should also be considered in patients who've got unilateral tinnitus, because this may signify some underlying pathology. Pulsatile tinnitus can have several different causes. These can include irregular blood vessels, high blood pressure, raised intracranial pressure, anemia, atherosclerosis, paragangliomas, or osseous pathology and glomus tumours. The underlying cause of the pulsatile tinnitus can then be targeted with appropriate investigation. So patients who've got synchronous pulsatile tinnitus, we should be considering MRI scans of head, neck, temporal bone. And if there is suspicion of temporal pathology, a contrast CT of the temporal bone should be advised. So what about the management of patients with tinnitus? Amplification devices may be of benefit. Even if they have slightly reduced hearing loss, that will not interfere with their day-to-day function. By improving their hearing, we may be able to lessen the effect of the tinnitus. There's been no real documented evidence that sound therapy will improve. But outcomes can be improved with psychological input. Indeed, using individualized tinnitus-related CBT can be useful. In primary care, we may consider beta-histine, because beta-histine is used for Meniere's disease condition of deafness, tinnitus, and giddiness. But evidence does suggest there's no benefit by using beta-histine for tinnitus alone. So this guidance aims to improve care of people with tinnitus by providing advice to healthcare professionals on assessment, investigation, and management. It's important to reassure the patient and don't forget to do the psychological assessment of the impact that the tinnitus has in their day-to-day function. Thank you for listening.